Fact, anything about a migraine that makes them helpful. In rare instances, they can be used for rescue. And if you look down there, butorphanol or Stadol nasal spray is a mixed opioid agonist-antagonist. So that helps with the addiction potential. So that one is one to kind of keep in mind for severe. So only acute, only in the emergent treatment. It's one of those that you'll get into problems with overuse, headaches, if they're on an opioid, and they could very well come to you on one. That people have thrown up their hands, or they've been on it a long time. They could have been on it 10 or 15 years ago, and somebody just keeps writing the script for it. So keep that in mind. Antiemetics. I think I've hit most of these, using them especially in patients who have a history of it, especially the drugs, especially the triptans, ergotamines are very amidogenic, so using those. I think I've got them all listed there for you. Other agents, steroids, only in very limited. So did y'all talk about status migrainous? So that's just like a headache that will not go away, very intense. And so there they have, steroids may be of help, just to decrease the inflammation for short term, so rescue. Others, intranasal lidocaine, valproate, magnesium sulfate. Some have recommended like taking magnesium on a daily basis as a prophylactic. But this is very limited data. With the drugs we have now, rare that you would see these. The next 2 pages, I've made algorithms for you in terms of treatment of migraines and prophylactic. So that's what those 2 pages are. So that's mostly abortive and rescue therapy. So now looking at preventative or prophylactic. So here we're wanting to minimize the severity of the migraines. It will not cure them. So 2/3 of patients will get a 50% reduction in headaches. So that can be significant for people. So indications, when it starts interfering with their daily routine. If they fail in acute therapies, let's say it's just not as effective, that's maybe due to overuse, so putting them on a prophylactic. Lots of side effects, neurologic injuries that are increasing. Frequent headaches, more than 2 a week. Increasing frequency, developing rebound when they come off of those abortive therapies. Menstrual migraines are very specific. We're going to talk about those. Those are more intermittent, episodic. So we usually don't give them drug all the time when they only need it for a few days of the month. Patient preference, so the patient may want to get tired of the drugs or the frequency, even if it doesn't meet those criteria, could be considered. There is no precise, this is when you do it, but this is kind of something people use in practice. More than 4 headaches per month, migraines per month, or ones that last more than 12 hours. So kind of gives you a guide. Anything along that line that I've said to this point that he and I disagree on? Okay. Main goals of preventative: reduce the attack frequency, improve the responsiveness to abortive therapy, improve their function, reduce their disability, keep them in school, keep them in the home, functional, keep them at work, prevent progression to more chronic migraine. Okay. Principles of treatment. I don't know why I could not manage the size of the fonts in this section, but it is what it is. So it's individualized, patient-specific, based on their pattern. Start low and go slow. This is on the second bullet. Increase gradually. You're either going to go to the point where you've got the effect you want or side effects prevail. which is is similar with all drugs. So again, here, this comes back to what I said before, adequate trial. So we expect good response in the first month, but maybe not perfect, and continuing this for at least 6 months before you decide, is it working? Now, that doesn't mean if headaches come, I mean, not headaches, but side effects come about that patient can't tolerate or refuses the drug, that you can't switch course. But as long as you've got something that they're responding to, giving them that 6 months before you decide whether or not it's going to work. The overuse, I can't emphasize enough. Did y'all talk about medication overuse headaches as a specific group? Did you? Okay. Triptans are one of those drugs that people will overuse. Abortive treatments, too much, that will then lead to rebound. I'll talk about that in just a little bit. Opioids, barbiturates, don't use them. That's for you. Talbotol comes in there, other pain medications. Pregnancy. So women of childbearing potential need to be warned about valproate, is a drug we can use for prophylaxis, topiramate. So those drugs we would want to avoid in pregnancy because of their teratogenic effects. Migraines can improve over time. The course of them or their frequency can change. So having times where you reevaluate therapy and the need for ongoing therapy is warranted. Adherence always should be assessed for any drug. And then what's their comorbidity, especially as they're growing older. Are you aggravating an underlying disease? Okay, so those are general comments. Now I want to go into just specifics about the agents themselves. So beta blockers have been around a long time. They've been used a long time for migraine prophylaxis. They're best in younger patients, so those under 60, or those who don't have existing heart disease. So those over 60, those are smokers who have existing heart disease, don't use a beta blocker as your first choice. It increases their risk of stroke. How it works? Not sure. Probably decreases the sensitivity of these nerve fibers to catecholamines, probably one thing. The other is that they raise the threshold for irritation by those neurons to serotonin. Propranolol's been used the longest, it's cheap, gets into the brain very easily. So the dose here is 40 to 160, usually in divided doses. So 20 twice a day would be a good starting. Timolol is a drug, been around a long time. People don't use it very often. It just doesn't come on people's radar very much. We'll see it more in glaucoma. Post-MI has a lot of data, but it is one of the drugs that has data behind it. Usually it can be given 10 to 30 milligrams a day. Most people start at 5 and will titrate it up. Metoprolol, your old friend, you know this one, should know this one well, 50 to 200 milligrams a day in 2 divided doses. So propranolol, non-selective. So your patients who have got underlying bronchospastic disease probably ought to go with metoprolol because it's beta-1 selective, right? Okay. Reducing frequency of attacks 50% in the majority of patients. Others that are also effective are atenolol and nadolol. They just don't have as much data behind them. Atenolol could be, it's a once a day, so that might be advantageous for some. Nadolol is a water soluble. So if you have people who can't tolerate the central side effects of propranolol, nadolol would be a good one because it doesn't get into the brain as easily. You ought to know the side effects and the contraindications to beta blockers in your sleep. I ought to be able to ask your partner or your roommate to wake you up and go, what are the side effects of beta blockers? And you ought to be able to repeat them back, okay? They don't change when we go from one disease to the next. It's like the baggage they drag with them. Contraindications, side effects. So there they are again. Fatigue, depression, that's mostly with propranolol. Nausea, dizziness, any drug can cause nausea. Dizziness, insomnia, vivid dreams, these are mostly propranolol, central effect. Bradycardia, you should know. Impotence, you should know. Contraindications, bronchospasm. CHF would be unstable heart failure. Peripheral vascular disease will just make it worse. AV conduction disturbances, so greater than primary block, AV block, first degree AV block. Depression and diabetes would also be a relative contraindication. If you can't use a beta blocker, verapamil has been used. It's more that it's used and people know about it than it has data behind it. So evidence, the 3 beta blockers I gave you have evidence behind them that they're effective. Verapamil could be considered. So if you've got those over 60, people who smoke, can't use a beta blocker, you use verapamil. Also can use verapamil in combination with like topiramate or one of the centrally acting drugs. Okay, next page. The antidepressants. You've heard about these before. Amitriptyline, tricyclic antidepressant, very old drug, been around 50, 60 years. Venlafaxine is an SNRI, so it works on serotonin, norepinephrine receptor inhibitor. These have evidence that they are effective. Amitriptyline has good effects on pain control. It works on substance P, and that is one of the neurotransmitters that increases pain. So we'll see amitriptyline come again when we talk about peripheral neuropathies and diabetes. It's very good for that. It just has some side effects that make it harder to use. One is it's very sedating, so people like to take it at bedtime. It's very good. Can have a hangover effect. You can wake up in that fog that takes a while to burn off. It also has anticholinergic effects. It affects those receptors, and so as dose escalates, the anticholinergic side effects will go up. It also has conduction defect side effects. So in people who have heart disease, better to stay away from. Special, I think, bundle branch block, it will make those worse. Okay, so younger patients, it's pretty good. Starting at 10 milligrams, that is an extremely low dose. 20 to 50 milligrams a night is a very reasonable dose. It's cheap, very cheap. Venlafaxine Xr is a SNRI. It's one of the drugs they've used in trials, and it's effective. Usually starting at a low dose and titrating up. So it's another one. So if you've got people who've got comorbid problems, like they've got insomnia, amitriptyline would probably be a good choice. Coexisting depression, you can treat 2 birds with one stone, kill 2 birds with one stone. The anticonvulsants, valproate and divalproex, so Depakote, Depakine, and topiramate, all have also evidence behind them. Topamax, probably one of the best in this group. Very good at chronic prophylaxis. The biggest problem with it are the side effects. Again, they start at low dose, 25 milligrams a day. It's also usually a once a day drug. Titrating up, I think you can go as high as 100. Remember the ADRs, paresthesia, anorexia with significant weight loss in about 10% of people, and also those cognitive impact, word finding being one of the more specific. The other one I didn't mention when we talked about it last week were kidney stones, but also if you've got a history of kidney stones, avoid it. So if you have patients who have also comorbid diseases like bipolar, seizure, anxiety, these drugs may be good to use to try to do both. Adverse effects, go back and look at the seizure handout I just gave you. I've listed some of them there: nausea, the hair loss, the tremors, the weight gain, fatigue, the hepatotoxicity, which was more a problem in kids than in adults. Contraindication, pregnancy, valproate's very teratogenic. History of pancreatitis is with valproic acid. It's a very low risk, very rare. But if you got somebody who's got a history of pancreatitis, just use something else. And then liver disease. Questions about those? So these are all prophylaxis. So young patients, look at the beta blockers. Young men, you may have to move to something else. They'll complain about the exercise intolerance, the fatigue, and the impotence. That's why looking at what else is going on with these folks and matching the drug up is a good idea. The NSAIDs can be used. They're very effective in terms of the inflammation part. Naproxen has the most data behind it. So headaches that have a predictable pattern, like a menstrual migraine, starting it a day or two before the expected onset of the headache and treating through it. We'll talk about that a little bit under menstrual migraines. Of the triptans, triptan is, remember, it's one of the very long-acting, probably has the best data behind using it chronically. Also naratriptan and zolmitriptan. Botox. Okay. Lots of interest in it these days. No, but this, remember, we're talking about prophylaxis. So no consistent, statistically significant benefit of Botox in the treatment of episodic migraines. Okay. It's not recommended for preventative treatment of episodic migraines. However, there is evidence for Botox for the onabotulinum A, remember there's 3 of them in that category, is effective for the treatment of chronic migraine. So 15 or more days per month for at least 3 months, with at least 8 of the 15 fulfilling criteria for migraine without aura. So it's very specific. So if it's popular, that's due to more than evidence, but there is evidence for chronic migraine. Okay. Lots of other things that have been tried and used. There's a lot of over-the-counter herbal products that are out there. Some of them have small amounts of evidence for them, but the majority are, I've given you, you have a lot of drugs to choose from, a lot of categories, lots of drugs that act differently and have different sets of side effects and can work with other comorbidities. Look at them first. All right. So that's all I have to say about those migraines. Any comments about that? Okay, let's look at the menstrual migraines. They are very specific, but because migraines affect more women, these become a very common problem. So there's menstrually related migraines, so they may have migraines during their periods, but they also have them at other times of the cycle as well. Then there's the pure menstrual migraines. Those happen only during their cycle. I'm sorry, during their periods. Okay. All of this is thought to be due to drops in estrogen levels. So we're going to talk about how do we combat that. Most common disabling condition in reproductive age women. Isn't that incredible? Menstruation may be the most potent and common of all migraine triggers. I think you told me that he said that? As a trigger, okay. Up to 70% of women with migraines report menstrual association. So the more common one is menstrual-related migraines, and the pure menstrual migraines are less common. Usually they are migraine without aura. And it's thought to be those drops in estrogen levels. Okay. So rescue therapy is the same as what we've already been over. Triptans, NSAIDs, ergotamines, all can be used. Prophylaxis for the pure menstrual migraines. The triptans have a lot of good evidence. The longer acting products are better. So frovatriptan, naratriptan, probably the best. Depending on choice also, you could look at naproxen. If you look at -5 days to +5 days, what that means, the day that the period starts, that is day 1. Okay, so minus would be the 3 or 4 or 5 days prior to starting a period, and then the plus goes in thereafter. So here it is that you would need diaries. Usually, and to document when they started. Then you're going to start a couple of days before and go a couple of days past. So that's what they're looking at there. So using estradiol, the triptans, or naproxen, all have data behind them. Okay, so what I want to look at on the next page are prophylaxis using estrogen products. So you can use, in women of reproductive age, you can use estrogen, progestin combination products to help, to prevent or to relieve, whatever. So if you look down through there, there's extended cycle products, cyclical estrogen with supplemental estrogen, the quadriphasics, and then estrogen supplements. So what they're doing is they're taking each of these types of combination or hormonal products and looking at where does the estrogen level fall off. So the extended cycle products, are you familiar with Seasonique? Okay, so Seasonique is of course you are. Of course you are. Because you work there, I mean you just spent some. Oh, well, more than we needed to know. Anyway, these extended cycle products usually are putting women on a dose of estrogen and progestin every day for 12 weeks. Okay, then they're they can be off for a week with placebo, or they can be like low Seasonique has just a low amount of estrogen in that 13th week. So what they have found is that most of these products, of these combination oral contraceptives, are going to have about 20 to 25 micrograms of ethinyl estradiol in every tablet. Okay. Not all, but most. They think that the threshold for those migraines coming on is when you get below 10 micrograms a day. So the recommendation is whether you're supplementing or whether you're using a product, on those off days, you need about 10 micrograms per day. Below that, migraine risk goes up. Okay. So you've got low Seasonique, which formulates it that way. The other is just to have continuous. You never have a placebo day or a low day. We do that with endometriosis. We just put people on a continuous cycle. So that's one approach. The other would be if women wanted to use cyclical estrogen contraception. That would be the old traditional 21 days of active drug and then 7 days of placebo. So if they wanted to do that, you still would need to supplement them with a small amount of estrogen to avoid the estrogen withdrawal. There are some products over the counter that have only 4 hormone-free days. There's one that has 2 hormone-free days. So there's different products out there you could match up, or you can give them a supplement during that time. The other is to use the quadriphasic. There's one on the market called Nastasia, and what it does is it incrementally lowers the amount of estrogen throughout the cycle. So in the usual follicular phase for women, estrogens are high, progestins are low. So what this product does is that about every 7 days or 5 days, it lowers the amount of estrogen in each tablet, at the same time raising the amount of progestin. That's what happens normally. As estrogen falls off to about day 14, we maintain a small amount. Then the progestin with the luteal phase starts going up. Okay? So that product can also be used because it lowers that estrogen over time, and you don't have a big fall off at one time. It does have hormone-free pills. I can't remember if it's 2 or 4 days. So that's another option. The last would be is if women have a contraindication. Let's say they're on a anticoagulant. You could use targeted low doses of estrogen for a very short period of time. Again, a few days before their cycle starts and a few days after. The lowest amount, and in that situation they use a patch. The lowest patch that is effective is the 0.1 milligram. So those are multiple approaches. In young women who desire contraception and they can tolerate and don't have any contraindications to a progestin or a estrogen, that is a very good approach. The biggest thing is not having big drops in estrogen at any time during the cycle. You'll either get breakthrough bleeding or you'll get a migraine. Questions about that? Okay. Let's see where we are. Tension headaches, most common. They're not going to come to you unless they can't get them to go away. The biggest thing with tension headaches is treating them soon. The longer you let a headache go, the harder they are to get under control. So having people take the drug at the beginning of a headache is usually most effective. The other is to look at how often are you using them. So the non-steroidals, the Tylenol, usually aren't going to be a problem for most people. It's when you start adding in other things. So let's say that they got their hands on butalbital or an opioid. That's where they can have withdrawal and rebound in those headaches. Let's go down to the bottom of the page and under medications. So any of the NSAIDs will work. Aspirin will work. Acetaminophen. Again, if they're going to use a Tylenol, at least a gram of a dose. So higher doses. If they work, it's probably better. It doesn't harm the GI tract. You don't have the cardiovascular risk that you do with the non-steroidals. So if they can get by with Tylenol, that's great. Sometimes using those combinations of small amounts, like in the Excedrin migraine, with small amount of Tylenol, small amount of aspirin, and caffeine. So those might be better for them. Let's see, next page, top of 22. Usually the over-the-counter doses are going to work. So ibuprofen strength is 200 milligrams. So using 1 or 2 tablets, that's what will be on the box anyway, is appropriate. Naproxen, 200. Again, if they will treat at the beginning of the headache, usually they can get it under control. So we're not going to do like we do with migraines, give them a big dose and then back off. Usually these lower doses are going to be effective. Other acute interventions, again, ones that contain caffeine may help folks. So keep that in mind. The Excedrin are one to kind of keep as a brand name in mind. Drugs to limit or avoid, opioids and barbiturates. Don't need them for tension type headaches. Butalbital I've talked about. Let's talk about those medication overuse headaches. Some of this you may need to take down. I didn't put a lot in your handout about it. This is considered to be a secondary disorder. So it's secondary to the use of agents like the triptans, the butalbital, the opioids, even the ergotamines. So this is due to regular use of those products, usually for more than half the month, for a period of several months, like 3 months. So every time they stop taking them, they get rebound. The headaches come back, so they take them again. So they get into a vicious cycle of rebound and treatment. This isn't usually going to happen with people who are just taking Tylenol or a non-steroidal. It's usually another drug. So it's like with the migraine folks. They're using a triptan now every day. They're aborting every day or multiple days a week. It's so they get rebound. Okay. So in these folks, you need to have a planned withdrawal. You've got to get rid of the drug that's causing it, which is really hard to do because they are going to have, those symptoms are going to come back. So treating them with a drug that from a different class. Naproxen is a good, what they call bridge drug, so that you can get them off the drug they've been using and get them under control, and then usually move them towards a prophylactic. So let's walk through that again. So you've identified that they've got medication overuse. You're going to put them on a drug from a different class, and you're going to bridge their symptoms until you can get them to a prophylactic or preventative treatment. So let's say they're using a short-acting triptan every day, or probably not every day, but multiple times in a month. Then what you do is put them on the naproxen. You're going to withdraw that drug, put them on naproxen. You do give them rescues. You do give them the ability to abort an attack, but you limit it, like twice a week. And then you move them to that prophylactic dose. This is tough. This is hard because their symptoms will be bad for a few days. But planning, talking them through, talking to them, how do you treat, things to that they can do lifestyle-wise. Knowing their triggers and addressing those and other lifestyle will help. Paul, if that's too noisy, you can shut it if it's bothering you.
It's closed all the way, so I don't want to close it.
The door's locked.
Oh, it locks, okay.
Do patients generally want to do this to get off of the rebound?
They may not. They might. If it's opioids, you will really have to. If they're using like a triptan or ergotamine very frequently, they're at high risk for side effects. So it's something you as a practitioner may have to say, we need to plan this. We need to move you towards a more reasonable, effective, because what they're doing now is reactive and it's not effective, and they put themselves at higher risk for more serious side effects. Not easy. I would say most people are like, no way.
Yeah, at the pharmacy, they did not want to move. They yelled at you because they ran out, and their doctor didn't give them more refills. Yeah, they eat them like candy.
So here's a way to avoid that. If you look at the very bottom paragraph, it's to avoid it is to manage and limit acute therapy. So for the triptans, limiting them to 9 or fewer days per month. Butalbital, 3 or fewer days per month. And non-steroidals, 15 or fewer days per month. Very bottom page of 22. Yes.
So when you do the planned withdrawal and then give them to the prophylactic dose, is
Yes.
that a dose of the original medication that they were on?
Doesn't have to be. Probably, you know, it depends on what they're overusing. You're probably going to go to a longer acting triptan or a longer acting like beta blocker or something along that line. So limiting at the very beginning is helpful. The big problem is that there's no way to track it. They can doctor shop and get around you, but you do the best you can. Let's see. So prevention, so that's the overuse. Come back to tension headaches for people who are having them routinely. There is prevention prophylactic therapy that has shown to be effective. One is back to amitriptyline, so using it on a nightly basis. Here you'll see the dose is higher than what we talked about for the so here it's starting at the 10 milligrams a night, but moving up to as high as 125 milligrams at night. There's limited evidence for the anticonvulsants like gabapentin or topiramate. There's limited, a lot of people use trigger point injections with lidocaine. So while it's commonly done in practice, there aren't studies to really have been done to evaluate. So what about Botox? This is for tension headaches prevention. So there was a big meta-analysis done of 8 studies that looked at Botox, botulinum, for chronic tension headaches. It led to a small reduction, 1 to 1.5 headaches per month that did not reach statistical significance. So some things that don't reach statistical significance become clinically significant if it's that patient. If to them 1 to 2 headaches less a week or a month is great, then it might be something to consider. So there's no data to support it, because there's just nothing that shows that it has a significant impact given what you're doing. So for Botox, there's very little indication except for chronic headaches, chronic migraines. Okay, questions about those? Okay, treatment of cluster headaches. You look over on the next page. I think our time, y'all have another class after this, right?
Yes.
Okay. All right, we got 7 minutes. We'll be done ahead. So here, the pain is terrible. Anybody in here ever had one, experienced one? They're not very common. Okay. So oxygen, 100% oxygen on a non-rebreather. 12 liters per minute. This is huge. That's a huge amount of oxygen. Usually is very effective. It's just that it doesn't last very long. But what it does is it gets the pain under control, and then you can move to put them on something else. So the triptans here, so sumatriptan, the subcutaneous, is effective. So you get them on the oxygen, you could use sumatriptan. An alternative is to use one of the triptan nasal sprays. The oral's too slow. The ergotamines can be used as well, but most they're going to go with the oxygen and probably those subcutaneous sumatriptan. Then you have to do preventative. So for these type of headaches, you're going to go right to prevention because they will come on again. So verapamil is considered first line. Topiramate also has some. Do I put that down here? Yeah, I may not be remembering that right. Lithium is hard to use. It has lots of side effects. Does have a serum concentrations that you can maintain. I think most people were going to go after verapamil because of the side effect is low. It's a high dose. So people who have heart failure or bradycardia are going to have trouble with that dosage range. Corticosteroids have been used to also help reduce admission or induce remission. So you can go oxygen, you can start them on steroid and verapamil with the intent that you're going to taper them off the steroid and maintain them on the verapamil. Questions about those? All right. I will see you in neuro. Thanks. Will you open that door? I see them out there.
Are you going tomorrow? No.
I appreciate it. Thank you very much.